A very good afternoon, dear all. I'm here to present my research work on barriers to screening for diabetic retinopathy among diabetic patients attending a tertiary care center in Kerala. So, diabetic retinopathy is the leading cause of blindness and visual impairment after cataract and uncorrected refractive error in India, and the prevalence was found to be around 16.9%, with the prevalence of sight-threatening diabetic retinopathy 3.6%, and that of mild retinopathy 11.8%. So, the causes of decreased vision include diabetic macular edema, macular ischemia, sequelae from retinal ischemia like retinal neovascularization, vitreous hemorrhage, retinal detachment, tractional retinal detachment, neovascular glaucoma, etc. So, the significance of diabetic retinopathy screening is that the visual loss or impairment due to diabetic retinopathy can be delayed by early detection, timely intervention in the form of prompt treatment. So, on reviewing a few literature, it was found that a large proportion of the patients had sight-threatening diabetic retinopathy at presentation, and the significant risk factors for delayed presentation include lack of knowledge, patients being asymptomatic, lack of bystanders, and cost, etc. So there is thus a lacunae of studies on barriers for screening diabetic retinopathy in this part of the Kerala, and hence the need for this study. Moreover, it is important to look why patients present late with sight-threatening diabetic retinopathy. So the primary outcome of the study is to find out barriers to screening for diabetic retinopathy in patients with diabetes mellitus, and secondarily to compare those barriers based on patients' response. So this is a cross-sectional study conducted in patients with history of diabetes mellitus attending the ophthalmology department of a tertiary care center, and patients of age more than or equal to 18 years were included, and they were interviewed using a pre-tested semi-structured questionnaire with consent. So this was a 6-month duration study conducted in 150 patients, and the barriers considered in this study include fear, lack of knowledge, felt it was unnecessary as no symptoms, transportation difficulties, inability to find time, no bystander, cost, difficulty in getting appointment, difficulty in doctor-patient interaction, tedious nature of follow-up due to other systemic illness, etc. So this is the questionnaire I have supplied to the patient, and it has details regarding demographic data, diabetes related questions like its control, other comorbidities, and few questions regarding the knowledge about diabetic retinopathy. So this is a barrier related question, as I have asked the patient to rate them on a 5-point scale from not at all important to extremely important. So I included the patients with both type 1 and type 2 diabetes with age more than or equal to 18 years, and those consented to participate in the study, and those with first visit to our hospital. Patients not able to respond to the questionnaire were excluded, and we found that majority of the patients were males and the mean age was 59 years. It was mostly type 2 diabetic patients, and most of them were well controlled. Complications was in minority of the patients like neuropathy, nephropathy, and most of the patients on oral hypoglycemic agents. So the primary outcome was found to be lack of knowledge, which was seen in around 66% of the patients, followed by absence of symptoms in around 56%. So among the patients who were aware of diabetic retinopathy, we found that lack of time or inability to find time for screening was found to be the most important barrier, followed by lack of bystanders and cost in the order. So we classified the study population into 3 groups: those with no diabetic retinopathy, those with non-sight-threatening diabetic retinopathy, and those with sight-threatening diabetic retinopathy. And lack of knowledge was found to be the most important barrier among all the 3. So the study highlights barriers in diabetic retinopathy screening in our area, which lead to delayed presentation of diabetic retinopathy. And knowing these barriers is important to plan strategies to overcome those barriers. So on reviewing a few literature, it was found that Indian studies mainly showed lack of knowledge as the most important barrier, whereas foreign studies showed that too many appointments, cost, transportation, language issues were the important barrier. Finally, our studies conclude that lack of knowledge was found to be the important barrier, followed by absence of symptoms, inability to find time, and lack of bystander, cost, transportation, fear, etc. in the order. So the limitation is that this was a small sample size, and the questionnaire may be better distributed in a diabetic clinic. So I conclude that the information obtained is important to implement strategies to increase the awareness of diabetic retinopathy and overcome those barriers at primary healthcare level so that delayed presentation of diabetic retinopathy can be prevented. I recommend physician or diabetologist should be informed about diabetic retinopathy screening, patient counseling regarding regular screening, community-based outreach programs utilizing digital tools, artificial intelligence apps, and social media, providing more flexible screening options and providing financial incentives or coverage for screening. Thank you.